Hello, everyone, and welcome to the 9th COVID-19 based Global Tracheostomy Collaborative webinar series. I am Vincia Pandian from Johns Hopkins University, the chair of the GTC Education Committee, here with Michael Brenner from University of Michigan, the president of Global Tracheostomy Collaborative, and Amy Freeman Sanderson from University of Technology, Sydney, who's also a member of the Global Tracheostomy Collaborative Education Committee. And we're really thrilled that you're here with us as we present on innovative approaches to tracheostomy education of healthcare workers during COVID-19. Many professional schools do not have formal curriculum that covers every aspect of post-tracheostomy care, and so it's imperative that we, especially at the hospital level, have formal trainings for clinicians on tracheostomy management skills, especially managing airway-related emergencies. One of our GTC Education Committee members during one of our meetings, Diane Randall, was sharing how it has been very challenging with the social distancing rules to be able to continue pre-existing educational modules or programs. Education must go on, but you cannot meet in person. So how do you become creative in delivering the content amidst these obstacles? And so we have a wonderful group of expert panelists who will discuss ways to identify effective curricular methods for teaching tracheostomy management skills and related emergencies, and how to assess the effectiveness of these innovative methods and share insightful lessons learned along the way with COVID-19 pandemic. Our webinar today is sponsored by an unrestricted educational grant from Medtronic and Smith Medicals. But please note that none of our speakers are funded by either of our industry sponsors and do not have any conflict of interest to disclose. If you have any questions, please type them into the questions section on the control panel, and you can do so at any time during the session. With that housekeeping thought in mind, I will hand over to Michael to introduce our lovely panelists.
Thanks, Vincia, and I appreciate your organizing such a terrific session. So we've got a wonderful group of distinguished panelists. They include Michael Safranek, who's a nurse manager at Seidman Cancer Center, Jack Ross, a senior physiotherapist at Tracheostomy Review and Management Services, Jerome Hamelin, who is a clinical nurse consultant, also at TRAMS, John Graham, a specialist anesthetist, and also joint director of airway and simulation at Melbourne, Australia as well, and Jennifer Benjamin, who's assistant professor in the Department of Pediatrics at Texas Children's Hospital and Baylor College of Medicine. So our first speaker is Michael Safranek. He brings an impressive background, including over a decade of experience in surgical oncology of the head and neck. He's been involved in actually instrumental in developing a care pathway that allowed patients to get out of the hospital more efficiently. And in their efforts to expedite discharge planning, they've risen to well above the national average in that regard. He's also a tracheostomy super user and involved in the development and spearheading of the Code ENT team that assists with response to emergencies and tracheostomies, as well as work with the difficult airway cart. So he's going to talk to you about the value of collaboration and some of the innovations that he's developed at Cleveland. Take it away, Michael.
Hi, everybody. A couple topics I'm going to review today are ENT emergencies. We're going to talk about how do we ensure best practices across our hospital, streamlining tracheostomy care across different specialties, and how we change our education process not only to provide effective and evidence-based education to our patients, to our staff, and also the care provider when they go home. One of the most important parts that we cover is the type of training that we supply for our staff and how to mitigate any kind of ENT emergencies. And these ENT classes are in person, and we've had to change a little bit based off of the COVID-19 restrictions. So you can't have as many people, they're more virtual, but we cover a multitude of different topics, talking about unplanned tracheostomy care, acute occlusion of tracheostomies and laryngectomies, emergency arterial airway bleeding, emergent bedside tracheostomy placements, and how do we effectively transfer the patient safely to whether it's the ICU, the operating room, or interventional radiology. And so to the left here, you'll see our what we call our bleed cart. It's like our bleed emergency cart, and there's a multitude of things. It's never this messy, but we have things on there just so you can see it. But one thing in front of you is see a decannulation kit. This allows for quick, fast, effective recannulation of the patient at the bedside. The bottom two drawers are packed with PPE because we've always in these classes have made a really big emphasis of protecting the staff and protecting the patients during the time of an emergency. And so we've always focused on, putting on your face shield, putting on your mask, your goggles, gowns, gloves, everything. So the changes though with COVID-19 is that PPE is an all-time high demand. And so how do we still train our staff and not waste our PPE? So we do kind of what are called dry runs, and we talk about what we put on, when we put it on, and make sure that everybody who is going in the room, you have that person who is manning that cart saying, hey, you don't have a gown on, you don't have a glove on, whatever the case may be, and to really have a nice checks and balance system put in place. Another topic is hospital and system-wide tracheostomy super users. Super users have been a really great form of education on whatever topic you're trying to use, because this allows not only to involve your staff, but to involve anybody who may be interested in that specific topic who may not work on that specific unit, and they can learn and evolve with the evidence-based practice as they evolve as a nurse or a healthcare provider. So the purpose of a super user is to help coordinate care and navigate questions related to daily tracheostomy needs. So how frequent someone needs to be suctioned, they feel a little bit uncomfortable, I'm seeing something I'm not used to, so you mind coming and taking a look at the patient. So we come to the bedside, we educate the staff, we educate and make the patient more comfortable and confident, and we mitigate any kind of future or potential problems that you may have. We facilitate unit-based training and in-services. One of the things we like to cover is asking those divisions, what are your biggest fears and biggest barriers to having a tracheostomy on your floor? And so when we go, we want to make sure we cover those top 4 or 5 topics before we start running through how to suction, how to change out a trach. We also assist staff with getting all the supplies that they need at the bedside, whether it's suction setup or so on and so forth. Our future goals is to expand the super user role across a community setting. So in our practitioner's office, you may have a patient who goes and sees a general practitioner who has a tracheostomy, and that general practitioner may not be familiar with it. And so if they have any questions or concerns, they can reach out to that super user. Super user can come and help not only educate that practitioner, but help the patient feel more comfortable and overall have a safer visit for the patient. Another part of collaborating and getting our patients the best care that they need, we have what's called the Code ENT and its evolution. So we have the 1.0 version. You can see how small that is. That's our old Code ENT tool bag. And the purpose of this Code ENT team was to respond to emergencies or code blues for patients who had artificial airways. So someone who had a tracheostomy or laryngectomy. The big issue with that is that, someone has a tracheostomy or laryngectomy, we can't breathe artificially for them like we would traditionally for someone who doesn't have a trach through their mouth and their nose. So you have trained head and neck doctors, residents, nurse practitioners, and nurses who go to those bedsides and make sure that if there's a difficulty with the patient, we are able to assist in establishing a patent airway, which is increasing survivability of the patient. The version 1.0 I showed you, which is the yellow and black bag, that was really great, but it has really evolved into this DART cart that we call, or a difficult airway cart that's in this picture. And these are strategically placed throughout the hospital and they're put on departments or in divisions that are most likely to have a difficult airway emergency. And the same thing with preparing for training for head and neck emergencies or ENT emergencies is the same thing what we do with our ENT DART cart. The bottom 2 drawers have a lot of PPE. We have a huge emphasis on protection of the staff, protection of the patient. The other things that are in the difficult airway cart or the DART cart is a tracheostomy kit, I told you about all the PPE that we have. You can see in the upper left-hand corner, it's a mobile disposable ambu scope that's very helpful for multiple care providers in the room to see exactly what they're viewing, and then headlamps and etc. The cart is evolving. As you can see, 1.0, this is what it was last year, and then what you see in front of you is what it is this year, and it's probably going to be something a little bit more effective next year. Another important topic is streamlining care across our specialties. What you'll find is different specialties may care for tracheostomies in a little bit of a different fashion, but at the end of the day, the patient has a tracheostomy. So we need to make sure that they have the best care that's evidence-based for a streamlined stay and discharge. So we enhance care with interdisciplinary collaboration with the surgical teams, speech therapists, nutrition and dietitians, and home health care, because our goal is to make sure that these patients go home healthy, and we want to get the 80% or greater of our patients to get discharged home where they feel more comfortable. So there's a lot that you have to have involved in order to ensure that. We also need to involve our families and caregivers in this education, because not only is the patient going to be involved in the care, but so is the family members or whomever is living with them. And they are sometimes going to be the best advocate for that patient when they're at home. And the most important thing out of this whole slide is addressing the biggest concerns and questions of the patient. You know, stopping and listening to them on what are they fearful for, and educating them, because a lot of times that fear can be mitigated with some extra time and some extra education with that patient. And lastly is how do we train our staff, how do we train our patients and our caregivers in order to get them home safely and in order to give them the safe care that they deserve at the bedside. So the nursing staff education that we do, it's we do completed yearly competencies that are evidence-based. We also ensure, part of this is ensuring that there's a consistent and uniform message and care given to each care provider and each patient on each and every day. Many times we've all been part of education sessions and one nurse or one physician may teach something a little bit different. We need to have the same message every time, because we have to understand we're teaching this person a very new skill. And so how do we teach the families and the patients on how to properly suction themselves and do this education, especially during COVID-19. Traditionally, Simon Cancer Center, we've always had our patients come in. They've come in all day long for intense education sessions. But now with the restrictions, especially being a cancer hospital, you're limited to a very short period of time during a hospital stay. So how do we augment those education sessions? We have a combination of hands-on learning. So they have a session of a couple of hours. We supply education videos, but the coolest tool is we use Cisco Jabber. It's kind of like FaceTime, and we give the patients and their caregivers a link. We bring this iPad into the room, and each time we're getting ready to do education to the family, we dial into the iPad, and the family members are able to watch in real time what we're doing. They can see the patient's mannerisms, and they can ask real-time questions on what's going on. So that way, when they do come in for the education sessions, they're far more confident and comfortable.
Thanks for a really outstanding session, Michael. That was incredibly illuminating, work that spans so many dimensions of what we're doing in tracheostomy care. So now we're going to transition to our next speaker, which is Jack Ross. She's an extremely highly regarded physiotherapist who's been part of tracheostomy review and management services for the past 18 years. She actually brings 25 years of experience, particularly specializing in the care of patients with spinal cord injury, also with expertise in CPAP and OSA. She's going to give us some valuable insights on learning theory as it relates to the care of tracheostomy patients. Thanks for joining us, Jack. And I think you may be on mute.
I was. Thanks very much. Thank you for that kind introduction, Michael, although I'm starting the day feeling a little bit old after hearing it. So I'm going to present some information about adult learning theory and how that's influenced the way that we provide our tracheostomy review and management service in the hospital. In Melbourne, we're currently under stage 4 restrictions, which I don't know if that has any meaning for everyone else, but essentially it means that it's very hard for us to provide any face-to-face learning at all unless it's 1 to 2 people at the bedside. So we're very reliant on the online experience currently, and I'll present some recommendations from the literature as well to enhance the online learning experience. So adult learning theory refers to 4 sensory learning modalities: read, write, oral or listening, visual, and kinesthetic, or what might be described as hands-on learning. In our previous models of education, TRAMS used all of these modalities by presenting information via e-learning packages, which are visual and read-write, lectures, which are oral, visual, and read-write, one-day workshops, which are all visual, oral, read-write, and kinesthetic modalities, and small group teaching, which has a large kinesthetic component and can be performed in a clinical setting, including bedside teaching. Incorporating all these elements into education strategies adds richness to the learning experience, and it also helps to capture the strengths of learners with different learning styles. Providing education in multiple modes becomes very important when we consider the work of Samarakun, who in 2013 identified that most undergraduate medical students were multimodal learners at that sort of 65 to 70% mark. But by the time they became postgraduates, as in our healthcare workers, 53% were actually unimodal learners. And this alerts us to the fact that we really need to diversify the way that we present information to people to try and tap into the strengths of each learner when they present. This is the kind of approach that we have in mind when we ask our learners to do e-learning packages prior to presenting at our workshops, and then presenting in all the different modes during the workshop itself. When we analysed the feedback that we received over a period of 10 years from our TRAMS course attendees and small group learners, we had a look at the sorts of things that people reported that they valued about education. So people report to us that they really like knowledgeable presenters, and we can certainly continue to provide this service online and probably even improve access to expert presenters by pre-recording at times that are convenient to senior presenters that we previously may have struggled to enlist at the times exactly that we wanted them. People also tell us that they value friendly and approachable presenters, and it's a bit harder to establish rapport online, but research in the field indicates that showing a presenter's face more often and not just concentrating on the slides will help with this. People also value the opportunity to ask questions, and this is certainly something that can be done in the online forum. If it's a smaller group, people can be unmuted and enable asking questions. In large groups, however, it's better to type into the sidebar, and feedback from some people is that they actually prefer typing into the sidebar rather than verbally asking a question. So this may enable people who are a little bit more shy about speaking up to really get their point more clearly across. People also who attend our course really tell us that they enjoy the sessions from presenters who have a tracheostomy. And again, this is something that the online platform really helps with, because at times if we have patients who live remotely, or people who it's quite hard for them to get out of the house at a particular time of day, if they can just drop in online, it's easier for them to access the session as well. And the final thing is the hands-on learning. People really value this, and this is really a challenge going forward to present in the online environment. And so we'll have a look at different ways that we may present that information. So some quick tips from the literature about how to improve the online learning experience. When we did a lit search in conjunction with our library staff, because they were also really interested in how they were going with their online learning. So the things that came up were establishing clear learning objectives prior to starting the session. Obviously, this is important for all types of learning, but it was another recommendation that came about online learning. The avoidance of text-heavy slides. Obviously, for people who have a read-write preference in the way that they learn, text-heavy slides may be useful, but in general, if you're presenting verbally and visually, avoidance of these slides is good. It can prevent people from being distracted by reading the slide. They can listen to what's being said. Again, the point of showing the presenter's face in order to give the disembodied voice a face and help people to relate a little bit more. The use of images and animation is something that you can really work on when you're presenting online and help to sort of move between the different modalities. Consideration of subgroups is talked about a lot when you're using online learning, particularly in long sessions. And this is not something that we've begun to do in TRAMS. We certainly use subgroups and small groups when we're teaching in person. But I'd be very interested to hear from anyone who's using this in an online learning sense in relation to tracheostomy education. And one of the other great things that you can do when you're recording online is to actually record the session for future access. And this is something that we've really embraced, and Jerome will speak a little bit about that when he speaks after me. There's also a strong use of a moderator is also strongly recommended from the literature. And hopefully you can see today how useful a moderator is in a session like this. They can help to keep things on track. They can introduce and transition between speakers, mute participants. They can line up questions and keep time and address any technical issues that may prove to be a distraction for any of the presenters. Use of quizzes is another thing that is also possible to incorporate when you're using online learning. Some platforms allow the presenter to insert these in, and this will break up the presentation, potentially re-engaging the learner to switch from a more passive listening mode to a more active mode where they're really contributing. And it will also allow them to track their progress and see if they're really picking up the information that's being presented. And finally, timing and screen fatigue. I think that at the moment we're all aware of screen fatigue. I think there's a lot of activity happening online now. So individual presentations such as conference papers are recommended to be down to 10 to 20 minutes as opposed to the longer in-person times that we previously had. Scheduling in regular breaks for people to get up and move around, and decreasing the amount of on time compared to in real life sessions to avoid people becoming fatigued by just watching a face and death by PowerPoint on screen. So my colleague, Jerome Hammerlin, will discuss some strategies that we've utilised in TRAMS to continue providing education while working with our current restrictions in COVID-19. Thank you.
Thanks for such a wonderful talk, Jack. You're clearly a consummate educator, and I think that the notion of multimodal training, especially the kinesthetic piece, is something that is really conspicuously missing in many of our programs. And overall, it's certainly underemphasized in education in the United States and probably most places. So maybe after your talk, all of our educational series will be a little bit closer to TED Talks. and I liked your picture of the moderator as well. So I'll try to be as bright and bushy-tailed as that particular individual. So now we can segue to our next speaker, which is Jerome Hamelin, and he's a clinical nurse consultant. He's had a very diverse background, spanning from beginning his education in Ottawa, Canada, and then New Zealand, and subsequently in Australia. He's part of the renowned TRAMS team as well. And so he's going to, his kind of trademark is quality improvement and ongoing patient safety. And so as Jack had alluded to, he's going to kind of speak to us about those aspects and agility and pivotability, if that's a word, as relates to tracheostomy education. So take it away, Jerome.
Thanks, Michael. So like Jack was saying, I'm going to talk a bit about how we've been able to pivot very quickly within the TRAMS team. And as everyone knows, providing education during COVID has become very complex and potentially unsafe for the educators to be delivering right at the bedside. And we also knew that stopping education was not the right answer. So we wanted to be able to continue to provide high quality education that incorporated the concepts that Jack discussed and maintain our safety while doing this. We wanted to continue to ensure that our education was relevant and address the changing environment. And we wanted to be sure that we also supported the changing policies that were happening all over the hospital, mainly relating to infection control and PPE guidelines. We wanted to ensure that we remained evidence-based and focused on patient safety and carer safety. So during Australia's first wave, we really focused on what we could do to ensure ongoing patient safety. So we focused really quickly on our policies and procedures, updating them very fast to reflect the new recommendations around PPE and aerosol generating procedures, but created a specific tracheostomy policy relating to those as well. So people had a really clear and accessible document to be able to reflect what the practice should be in relation to tracheostomy care during this time. So some of the changes that we made right then were stopping the uses of routine nebulization across the hospital, and specifically in our tracheostomy patients, the use of normal saline nebulizers to augment humidification. We introduced the use of inner cannulas in all of our patient groups, which was quite a shift in our organization because some patient populations wouldn't use them, specifically spinal cord patients with decreased respiratory drive. We reduced our exposure to AGPs by introducing closed suction and viral filters on all of our ward-based ventilated patients. And where appropriate, we encourage the use of spacers and metered dose inhalers rather than the use of nebulization for inhaled medications. We escalated our hospital-wide recommendations around routine tracheostomy PPE, which now includes the use of obviously masks, eye shields, gloves, and plastic aprons when directly providing patient care with tracheostomies. We continued to communicate and tried to streamline our communication across the organization, opting to lean in on our policies and procedures library to ensure one source of up-to-date information and to guide practice to optimize safety across the organization. And as the restrictions changed, so did our delivery of the traditional education model. We started to deliver a hybrid model of education, initially moving our lecture material into our virtual classrooms, and then continued to provide the hands-on education in person while observing social distancing practices. Then as our restrictions increased further and we were no longer able to deliver the one-on-one face-to-face education, we needed to be extra creative. Luckily at this point, our policies and procedures that had changed were firmly in place, and this allowed us to focus on the opportunity to adapt our kinesthetic learning component of our education model. As tracheostomy care is considered high risk and stopping ongoing education could pose an increased risk to patient safety, we discussed the idea of an online kinesthetic model and liaised with our deteriorating patient committee regarding this. they were very interested and agreed that we should try to implement some type of model as quickly as possible to maintain this education and to be able to have people learning. We knew that we had to be agile and flexible in the delivery of this education. So we had to have an approach with the new restrictions, and we had to have this real can-do attitude and be open to maybe not getting it right the first time. We adopted a test and learn philosophy, and we knew that completely online education and delivering this kind of model was going to be a learning opportunity, not only for us, but also the learners. And so we needed to be really collaborative with them, and we knew that it wasn't going to be without its challenges. Our organization already had some great resources created to support learners, so we really leaned in on those also. We encouraged self-directed learning with our e-learning modules, reviewing of all of our policies and procedures to make sure that people were up to date. We continued use of our clinical instruction sheets, which are very important to different care aspects of tracheostomy care. And we focused strongly on our safety by using our emergency management poster, which John will speak to. So how did we decide on what platform to use? And the answer is we didn't really decide on one, we decided on several. All the platforms have their pros and cons, but it's really understanding what the platform has to offer and how you want to interact with your audience. You should not be shy about using multiple platforms based on how you want to engage with the learners. Using whatever platform your organization already has in place obviously has its advantages, but mainly the familiarity of the staff and its use is really what you get out of that. But you definitely need to make sure that you leave extra time when giving online education, as you'll probably need to assist with some type of technical support. Where your internal platform is not always ideal is when providing education to carers, obviously external to your organization or for patients and families. When providing external care education sessions, it's really vital to leave extra time because these patients and families or external carers will need support in getting onto the platform. So when we looked at what we were going to be delivering, we looked to see if it was an internal or an external participant, what the functionality of the platform was, how long our session was going to be, what style of education was going to be delivered, the size of the audience, and obviously the security of the platform. These considerations helped us to decide which platform to use and when we were going to be delivering different types of learning. So whether it was going to be kinesthetic learning, or if it was going to be a refresher and update training, pre-op education, carer training, patient and family discharge training, or larger forums. So our creative way to pivot our kinesthetic learning was to host small groups online, where each person rotated through a simulation room to practice the tracheostomy skills. While one participant performed the skill, the other participants would virtually from another location on either their personal device or a separate computer would watch that person performing the skills. These small groups that rotated not only allowed the skill to be performed, but provided that kinesthetic learning component and offered the other healthcare workers the opportunity to learn from the successes and challenges of their colleagues. The sessions do require a lot of enrollment and collaboration with the education teams on the ground, mainly to assist in the setup of the room and ensuring that the practice materials are adequately cleaned after the session. The participants also need to have access to proper consumables and equipment, which can be very challenging at times, especially when you're doing online education to smaller centers or in rural or remote areas. To facilitate this, we often had to send a tracheostomy dummy or equipment in advance of the session, and this way that we can ensure the completeness of the care education and ultimately the patient safety. During these sessions, learners perform all the tasks in appropriate PPE and complete hand hygiene as if caring for the patient. This way it would also protect the learners from each other while they rotate through the simulation room. So we actually asked ourselves, and Jack talked to this a little bit, how can we really lean on online platforms in our new way of education to be able to reach as many people as possible? And we already see that when you have an online platform, that just allows multiple people from wherever they are to be logging in and participating. And so this increased our attendance already. But we also wanted to leverage on the ability to record our online lectures and then provide them to the individual units or healthcare facilities to be able to review it afterwards and ask questions, or be able to have people participate that couldn't be there for the original session. The recordings are also very efficient. They allow us to do one recording rather than visiting the unit 2 or 3 times in an attempt to get a bunch of people to the sessions. And as always, we always want to be looking at whether we're going to keep this on board and evaluating our changes. And so we've asked ourselves, what are we going to be able to be feasibly doing in the long term with this new education model? And are some of these pieces things that we want to keep, or do we want to be leaving them behind? And this is something that we're going to be looking very closely at.
Thanks so much, Jerome. It's really admirable, your versatility, innovation, and agility that you bring to this. I think that we're in an era where there's a great deal of just change fatigue, but there's this enormous need and gap in knowledge, and your perseverance in it and willingness to not get it right the first time and keep hammering away at it is really extremely helpful. So thanks for sharing those insights. So our next speaker is John Graham. He's a specialist anesthetist. His passion is both difficult airway and related simulation for it. He's been a major innovator in this particular space. He's also been part of the COVID-19 work group at the Austin Hospital in Melbourne. So we're very fortunate to have him here as a leader and member of multiple groups in the hospital that are concerned with airway and simulation. He's going to focus on the emergency tracheostomy management tool. That's really a particularly powerful and innovative device that can potentially be of use and interest to people across countries as well as across.
Hello, thanks for the opportunity to participate. My talk will cover aspects of our department's response to COVID-19, and I wish to introduce a cognitive aid we have developed at Austin Health. We've been involved in training with multiple groups within the hospital during COVID-19, but the majority of our department's training time has been spent in anaesthesia and the operating room. We emphasised during COVID-19 that the regular things still need to be done well. I'll pick up on that theme again shortly. We've also been concentrated on the special challenges of COVID, including modes of transmission and the implications for aerosol generating procedures, personal protective equipment, understanding the importance of air exchange and relative room pressures, communication challenges related to PPE and closed rooms, and managing equipment challenges. We have PPE training champions for one-on-one PPE training, virtual meetings to cover major content, and lots of simulation. Within anaesthesia, we are focused on providing care during insertion of tracheostomy and then being called to assist with tracheostomy emergencies. This is a photo of some of our team training in PAPAs in the room in which we perform tracheostomies in the intensive care unit. As an icebreaker, in smaller learning groups during COVID-19 times, I asked participants what they have learned from COVID. I've learned that some of my colleagues have extraordinary abilities in areas of policy development, logistics and equipment, leadership and simulation. I want to emphasise that I'm a role player amongst many other contributors to the material that I'm presenting today. Cognitive aids and checklists have been used widely in COVID. I wish to present a cognitive aid for management of tracheostomy emergencies that we have developed collaboratively at Austin and is not strictly related to COVID, but its introduction falls into the thinking that we still absolutely need to do the regular things well. Before I launch into it, I just wanted to remind you of some of the important understandings about cognitive aids. Cognitive aids are tools to enable an experienced individual or team reliably perform an important series of actions systematically to avoid fixation and without significant omission. They have been described as implementation tools to be used while managing the emergency and being specifically used for that purpose. They should be supported by other foundation material, notes, videos, policies, etc. that provide background information. They should support best practice and should be well designed. They should provide a shared mental model for the team and support communication. More complicated scenarios, such as tracheostomy emergencies, may require a reader to follow the aid in addition to a team leader. Finally, cognitive aids can be a focus for education and quality improvement processes. There are 4 stages to the introduction of a cognitive aid. COVID-19 has demonstrated that with major effort, this can be done quickly. The 4 stages are development or acquisition of the aid, staff familiarisation with content and how to use the aid, its use in simulation and in the clinical environment, and then eventual cultural change. It is difficult to familiarise you in the time available to the cognitive aid, but I'll do so briefly. The cognitive aid is A3 and is printed and laminated and placed at the bedside of tracheostomy patients. It is 2-sided. This is the front side, as is indicated at the top right. This side is for primary responders. These are the immediate bedside responders to a tracheostomy emergency. The user chooses which of the 3 emergencies, block tracheostomy, accidental decannulation, or bleeding from tracheostomy, that applies to their patient, and proceeds down the steps in that pathway. For the more experienced user, the title of each step next to the number can be used as a trigger. For a less experienced team, the cognitive aid reader can provide more details in the lighter section. On the far right, information about the patient's tracheostomy and upper airway are documented. You'll be able to see that in step 1 of each of the pathways, Respond Blue, which is the hospital cardiac arrest team, is activated. This side of the cognitive aid is intended to be used by the Code Blue team, which typically includes intensive care, anaesthesia and medical doctors, and an intensive care nurse. This team will have advanced skills, but may still not be expert in tracheostomy emergencies. The same 3 colour-coded pathways are used, but with slightly different titles. The purple pathway on the left is called difficulty breathing or ventilating, rather than blocked tube, so that the team consider alternative causes in the apparently blocked tube if it has not been resolved by the time of their arrival. A similar format of title of step with further information in the lighter background is used. For the purple and orange pathways, the users are advised to stop when the patient is stable and in bleeding to complete all steps. In the purple difficulty breathing ventilating pathway, in step 5, guidance is given about possible use of a bronchoscope. In step 6, after tube removal, the orange colouring assists in guiding the users to the next pathway, completely removed tracheostomy tube. In the far right-hand section, entitled In All Cases, principles to consider for use in all patients are listed. I should mention that we have recently submitted the cognitive aid for publication in anaesthesia and intensive care. In summary, I have discussed our department's approach to COVID, or at least aspects of our department's approach to COVID-19 education, and introduced a cognitive aid that we have developed at Austin Health for tracheostomy emergencies. Many thanks for the opportunity to participate.
Thanks, John, for a phenomenal talk. And I apologize that I toggled off onto mute when initially you began your talk and didn't give you a proper introduction. But John Graham has really been an incredibly important figure that has reflected in that very powerful emergency tracheostomy management tool. His passion for difficult airway and simulation has really moved the field forward, not just at Austin, but on a much larger scale. So thank you for sharing that, and that's something that at our own institution I think would be very helpful. Within the Global Tracheostomy Collaborative, we've actually put a tremendous amount of thought and energy into the capture of adverse events. And I think that what you've done so well is identifying really three of the top ones, probably the most important ones: occlusion, displacement, and bleeding, and then stratifying the level of complexity to the various audiences that might use it. So that's incredibly valuable. And also a tip of the hat to Jerome for a wonderful talk preceding that. So now we'll transition to our final speaker, which is Jennifer Benjamin. So she's an assistant professor in the Department of Pediatrics at Texas Children's Hospital and Baylor College of Medicine. She's been a real innovator in the area of e-learning and medical student education. Her talk focuses on the concept of virtual deliberate practice. She's really focused on the area of complex care in pediatrics, which is an incredibly important and underrepresented area. So with this talk, I think that we'll bring our discussion full circle with respect to implementing technology as relates to tracheostomy education. Thanks for joining us, Jennifer. You may be on mute as well right now. Well, Jennifer is working on the audio part. I'll just pitch a question. Why don't I start with Michael Safranek? I was curious with your code team, the code ENT, how often it's called and what the typical responses that you hear most frequently are.
Can you hear me? You know, I don't have the metrics for how frequent. I'd say probably once or twice a quarter. You're hearing it called. It's gone down a little bit more with, you know, we have different types of rapid response. So if we feel that the patient may be declining a little bit sooner, we can get them care faster and until leaving or until waiting for like a code blue to start, because the code ENT is really for that code blue situation. So avoiding that is the best practice. And that's what our code white or rapid response teams do as well.
Terrific. Thanks so much. Jennifer, let's see if we can hear you now. Looks like we're still having a little bit of logistical difficulty with that. Why don't I ask John a question too? So John, can you just give us some comment with respect to your emergency trach management tool, what the initial feedback with it is, and particularly as you look at individuals that have a greater or lesser degree of expertise specific to trach management, how you've found the device is able to adapt for those different users?
Thanks, Michael. The rollout actually was sort of meant to be happening during COVID-19, so it's made it challenging. And we've done a lot of testing with it during its development. It replaced trams have had very long established cognitive aid for bedside users, which they, as evidenced by the two speakers, are very good at training people in the use of. The staff that I mainly work with, anaesthetic trainees, come for us for quite short periods. And also the other group we've used it with is intensive care trainees. And so we've actually tested it a lot with both those groups and received a lot of feedback. And much of the design really reflects the use of the anaesthetic trainees, which have great technical skill, but often not a lot of experience with tracheostomies. And then the intensive care trainees have both great technical skill and great experience. And so that was the sort of origins of going for the sort of trigger points for the experienced person and a bit more information for the less experienced. But the feedback's been good. But it's been, I must say, in the anaesthesia department during COVID, the greater focus has been on managing the intubation of patients that present with COVID and need to go to the intensive care unit, and then actually managing logistics of theatre. And so it's been harder to get airtime with that group than it would have been if we hadn't had COVID-19.
That's wonderful. Thanks for that illuminating response, and for publishing that resource, or I guess it's somewhere in the process of submission and review, but I think we'll all look forward to having that broadly available. A question for Jack about the use of kinesthetic training and getting buy-in for that. So it may be culturally something that is more broadly adapted in Australia. But can you tell us what's been useful and just in terms of getting those who are involved in the teaching roles to implement those types of approaches? I mean, I'd imagine a lot of people, they've got sort of their usual boring slide deck or otherwise, and how do you get people to up their game?
I think this is probably a question that Jerome could perhaps answer more fully than myself, but one of the things, as I said in the feedback, people really value kinesthetic training, and it's something that is really consistent in our feedback because we've tried to provide it for a very long time. So we provide it at the bedside, and I was really interested to hear Michael talking about prior to families coming in, just getting that iPad there and doing the pre-training on camera with the family. I love that idea, and I think we could start using that because our patients are obviously, like everyone's, using a lot of iPad communication with their families, so we can start doing their cares in front of them now. So thanks for that, Michael. So I think I might tip to Jerome on how exactly it's being implemented, if that's okay, to do the kinesthetic training with the sending out of the models, that kind of thing, Jerome?
Yeah, why don't we have Jerome give a few words on that? And you know what I think we'll do if Jennifer's audio isn't working?
It's working now. Can you guys hear me?
She's on.
Okay, great.
Okay, fantastic. The joys of technology, right? So thank you, GTC, for this honor of presenting our work. It's our privilege. I would not be presenting our work without the input and hard work of our team, Dr. Flores, Dr. Jane, and Dr. Satid. Shout out to Dr. Satid, he's in the audience. So we created a virtual a module for deliberate practice. With the challenges of COVID, we had problems with limitation in learner numbers in the simulation lab, reduced in-person training, and the need for continued education with concerns with hygiene. To overcome all of this, we had to change our blended curriculum to a fully asynchronous method. And we scheduled time for our learners to address the limitation in the number of learners. And we wanted to create a module that is sustainable beyond COVID. And the learners sanitize the mannequin between their practices to keep in with the regulations of COVID. So we used the Payton and Walker 4-step method and approach, and we identified the signs of using this method to create social presence for online learning from TikTok. So we looked at TikTok videos which have complex steps and then have broken down steps to learn the skills. So it is similar to learning these complex skills that we want to teach as procedural skills. So the Payton and Walker defined 4 steps for procedural skills as demonstration, deconstruction, formulation, and performance. So this slide shows the graph for skill development. The bottom red line shows mindless practice, and the blue line shows the expected level of skill achievement. And you can see that with specific goal, intense focus, and feedback, that with deliberate practice, the skill level achievement of learners is much better than with just mindless practice. So how did we implement this deliberate practice to our module? So this slide shows the application of Payton and Walker steps to our module. So with the step 1 demonstration, the learners watched a video of an expert performing tracheostomy change without narration at normal speed. And then the step 2 was deconstruction, which is essentially a step-by-step process. So a detailed video, which is shown in slow motion with plenty of pauses for the learner to repeatedly practice the finer details of a tracheostomy change. Step 3 is formulation, when the learner actually records the performing a tracheostomy change. So usually the learner spent a lot of time with deconstruction to be able to then record their formulation videos. So they would record their narration onto an expert performing the procedure. And step 4 is performance, where the learner, after repeatedly practicing, then went to a sim lab and performed the tracheostomy change on a mannequin. So our course content, we used VoiceThread as our learning management system, and our course content was outlined in 3 brief animated videos, which helped our learners familiarize with the content over a very short period of time. And these videos were accessible through shareable links that were sent at the beginning of the rotation. So the next slide shows 2 example videos back to back of an animated tool that we used to create. It's called Powtoons to explain the course content. Let's get started with the online tracheostomy module, the VIDA program, using VoiceThread. VoiceThread is an interactive collaboration and sharing tool that allows for seamless online learning environment with audio commenting and feedback, video, texting, and much more.
Due to the COVID-19 pandemic and nationwide implementation of social distancing, educators and learners are facing challenges to efficiently undergo mandatory trainings. That's why we bring you the VIDA program. VIDA is an educational program developed by physicians at Texas Children's Hospital to overcome the barriers raised by the pandemic. VIDA stands for Virtual Delivered Practice for Procedural Skills Training. At its core, this program will provide a virtual training method grounded in a theory as an effective, sustainable solution.
So the first step of our module was a portion called the demonstration video, which showed tracheostomy change without narration, with the expert performing the essential steps of changing a tracheostomy tube in a seamless fashion at normal pace. The second step of our module was the deconstruction video, which showed tracheostomy change with pauses, narration, slow motion to highlight the pertinent steps. And the beauty of breaking it down was to allow our learners to repeatedly practice, allowing for deliberate practice. This video demonstrates routine tracheostomy change on a mannequin. Stand to the right of the patient if you are right-handed. This is a clean procedure, so remember to wash your hands. Identify the size and type of trach by looking at the trach size on the patient. This patient has a 3.5 PD Shiley. You will need a same-size trach, a downsize, trach ties, dressing, ambu bag, suction catheter. So once our learners watched the repeated step 2 video repeatedly, they were then ready to narrate the video, the steps onto and move on to step 3 of our module, which is the formulation. So having watched the deconstruction video several times, they were instructed to narrate the steps onto a video with the expert performing the procedure without any narration. And we left the hints that followed, like the animation hints that were in the deconstruction and demonstration video, to a minimum, for them to be able to narrate the steps. So they used the VoiceThread functionality of audio recording. The faculty were informed of this little blue yellow highlight informed the faculty of when we were ready to give feedback to our learners, to provide timely feedback to help them improve on their skills. So once they were ready to perform the step 4 performance video, by then they had repeated practice and feedback from faculty to move on to the next step, which is the performance video. So the next,
to do a routine trach change. I've already cleaned my hands since this is a clean procedure, and I'm going to be wearing my gloves now. First step to do is identify the type of trach that they have. They have a cuffless 3.5 PD Shiley. And then I have my equipment here. So this seems to be the new trach that we'll have. We'll have some lubricant for that as well. This will be the direct suctioning catheter. And this is some gauze and dressing. This is the downsize.
So these are our results. So the top left graph shows the confidence on a 5-point Likert scale before and after our module. It shows significant change in scores from 1 to 4 on a scale of 5, with the second graph showing scores of 4 out of 5 for the ability to list critical steps and the ability to perform a tracheostomy change. The graph on the right shows the feedback on the module prototype to assess functionality and the interface of the whole platform. It actually shows individual responses to our 12-item system usability scale questionnaire with mean scores of 74 with a maximum score of up to 100 and a standard deviation of 17. So in summary, we created a theory-informed virtual deliberate practice module prototype for teaching procedural skills, which was 100% asynchronous using existing technologies. The asynchronous aspect can be further enhanced with minimal coaching from synchronous involvement by faculty. Our faculty and learners had robust digital conversations while making learning enjoyable as they learned their practical procedural skills. And our module is sustainable beyond the pandemic. So the lessons we learned: by scheduling sessions for synchronous learning, we were compliant with social distancing guidelines. We learned the need for continuous iteration of iterative process to refine our module to be user-friendly, like Jerome was highlighting, the need for continual improvement. Providing simplified instructions with operating technology that residents were unfamiliar with. And we made a deliberate effort to make the online environment robust and interactive for feedback with improved social presence.
Thanks so much for a phenomenal talk, Jennifer. That was really illuminating. I know the audio part getting started was frustrating, but it was worth the wait. Those videos are truly amazing. And the notion of deliberate practice is really extremely powerful. The work of Kay Anders Ericsson has certainly influenced my career and that of many, and seeing it applied to tracheostomy is really phenomenal. So I'm going to hand it over now to Dr. Freeman Sanderson, who has an international reputation in her own right and has been quietly waiting to initiate the question and answer session. I know there are many in the audience that have had some very thoughtful insights, so let's take those questions.
Thanks very much, Michael, and thanks to all the panelists for fantastic talks and really informative aspects to education. I'll just jump to the Q&A panel questions first. We just had a couple of people just asking for copies of slides. So just to confirm that these sessions are recorded, the recordings are uploaded to the GTC website, so they are available for viewing again afterwards. So certainly we can post out the link again and you'll be able to access the talks there. We had Linda Morris, one of our other GTC members, pointing out a Clearview trainer for SIM, looking at a model head that you can look through. So thanks for that, Linda. I've got a couple of questions that sort of echo some of Michael's questions in regards to picking up some themes with training. And the first question goes to either Jerome or Jack in terms of the practicalities of staff accessing the training and patients or carers accessing training, and whether they're able to access or log into this particular training both on site at your facility or at home, and is this a sort of a secure place, or is it easily accessible for people to access?
I guess it depends on what aspect of the education you're speaking to. If you're talking about the kinesthetic online learning component, where we're delivering that at a distance, then yes, they can log in wherever they are. They can do it from home or at work. But if they're needing to be in person to do the physical hands-on portion, then they'd come into the facility, but be at distance in different rooms. So it is kind of a conjoined, multifaceted way of doing it. We'll deliver the lecture portions before they come to do the kinesthetic component, or they might just need to purely do the kinesthetic component. So I guess it depends on who you're delivering it to and the structure of the education and what steps they're going to have to go through first before performing the skill.
Yeah, and I mean, I'm thinking about, globally, the increased need of people that we've needed support with training and people sort of accessing components of training after hours, or we know that hospitals are run 24 hours and at home, the care is needed 24/7. So it's great having that accessible for people to, log in and do those lectures at any other time. John, if I can ask, if you're still on the line, and I can ask you a question about your publication of the tool. I'm just wondering if there had been any feedback internally about sort of use of the tool, if it's been used in any sort of evaluation in regards to use and ease of the tool in terms of the decision making and improved outcomes.
Oh, look, we haven't. It's literally sort of in the process of being rolled out at this time. So we've in its design, we did a lot of that stuff. So that was as everyone listening will know, designing something for tracheostomy emergency is incredibly complex, and there's an incredibly different number of people who might respond in terms of their level of comfort and expertise. So it's something we've sort of, myself and a few of the other people in the hospital airway group with trams have struggled with, at least for the group beyond trams. I think the primary responder stuff's been very well organised in our hospital. So we had a previous cognitive aid that we had some issues with in terms of its usability. So we really tested this a lot in simulation with our nursing staff and with in places like the recovery room, and also with the medical staff, ranging from very junior to more senior medical staff that might get called to these emergencies. And we really listened to their feedback and tried to incorporate as much as we could of their design. And we got a communications designer involved as well. We realised that it was we needed expertise beyond that of the clinicians and users to support that. And then I think we're on to about our 23rd or 24th version at the moment. So it's been a lot of editing and changing and things as we've got feedback as we've gone along from both sides of the aid.
Yeah, thank you for that additional insightful feedback in terms of the development of a tool, because it's it looks like such a clear and fantastic tool, and it's very useful to know in terms of the steps needed to get it to that polished level. And I think that's fascinating, the concept of actually doing SIM and working through the policy and procedure, or the flow chart. Does it work? What do we need to change? So that's really fantastic insight. So thank you for that additional information. I've just got two more questions, if I may, because I'm aware of the time. This is to Michael, in terms of your carts, your DART carts. just in terms of practicality questions for our viewers, listeners out there that are interested in these carts, in terms of how did you initially sort of get funding to get them, and whose responsibility is it to stock and check it? Because we know that checking carts adds to the safety. So how do you do that at your facility?
So the original, so the 1.0 bag, you know, we just kind of stocked with the stock that was on my division. But now what we do is they're locked carts. And so when that cart is, the process of is when that cart is used, once it is used, it is switched out just like a crash cart would be on the normal division. And so the department that is responsible for restocking, sterilizing, cleaning are the ones who go through. They make sure all the equipment is not expired, everything is clean, and and repurposed, wrapped up, and then delivered back to those units. And then that unit will pay for the cart. It's a evolving process because it's gone from a bag to a cart. But the system that we have in place actually results in less waste of material because you have exactly what you need and less waste of time running together.
Yeah, thank you. Because I know that those sort of certain practicalities are the, you know, the necessary bits of information that you need to know, you know, whose responsibility, because and who's going to pay for it as well. So last question, if I may, to Jennifer, in regards to your TikTok videos and breaking it down. I think that's a fantastic concept and really tries to consolidate some of the learning and picks up on what Jack and Jerome have spoken about. I'm just wondering about in regards to the, I guess, the confidence. You displayed a graph of yours pre and post. Was that across different skill levels, or was it a certain level of trainee or health professional? Can you just give us a little bit more information there?
So our module currently is, yes, the questionnaire we gave them was a 12-item questionnaire. And we do the self-efficacy, confidence across different parameters as well. But our learners have mainly been interns and medical students because of the nature of the rotation and the curriculum. But our hope is to then use this approach to use for other procedural skills. So we just implemented VoiceThread in our institution. So we're hoping to use this as the exemplar model, if you will, for other learner groups and for other procedural skills.
Yeah, so you could see it be really beneficial across for patients and families as well in terms of confidence and skills. Okay, thank you. I'm mindful of the time, so I'll hand it back to Vincia and Michael.
Thank you, Amy. Thank you, Michael, and all the panelists. It was such a lovely talk, and to really hear about all the exciting teaching modalities that could be used for our patients. So thank you. I do have all our panelists' emails here, so if anyone wants to contact them directly, you can. We will also be posting a link to today's webinar recording on GTC website, so you should be able to view it in the next 24 hours or so. And please do share with your colleagues who may be interested in hearing about this. And a lot of these technology are just evolving, or we're using some of the existing technology for our trach patients. So some of the approaches or nuances are different. So if you do want to talk to our panelists, they are available. So please do note or save the date on your calendar. On October 1st, around 4 p.m. Eastern Standard Time is when we'll have our next webinar, and we're going to focus on telehealth and how do we use that to care for our trach patients. I think telehealth is being used for patients in various settings, but in terms of our trach patients, especially when they can't communicate, how do we address those issues? So please do join us to hear more about that. So thank you, and see you all soon. Please do join us by going to www.globaltrach.org. Thank you again.
Thanks.